Good morning and welcome to the WAVY Digital Desk. Today's community chat is about a new Sentara study that will take place over the next 5 years to address hypertension in underserved communities. And we have Dr. John Brush here, a Sentara Chief Research Officer, who's going to talk to us about this study, the importance of it, about the grants they got for $3.4 million to carry this out, and more. So Dr. Brush, thank you so much for joining us today.
Thank you for having me. It's a pleasure to be here.
Absolutely. You know, I'm sure some people have heard of this study, and tomorrow night I do want to say Marielena Balouris will have more on this on WAVY TV 10, so please head over there tomorrow evening to see even more about this study and grant that will take place over the next 5 years. But Dr. Brush, could you just give us a little bit of an overview about what this study is?
So the study is aiming to improve blood pressure control in patients who might be considered vulnerable populations. Hypertension is a severe problem in the United States, affecting roughly 40% of Americans. It disproportionately affects African Americans, and it leads to fairly severe, if untreated, it can lead to severe outcomes: stroke, kidney failure, heart attacks. And so treating blood pressure adequately is a very, very important thing for healthcare. But it's hard. It's hard to treat, and particularly in vulnerable people. It requires follow-up. It requires attention to the details of taking medications properly and what have you. And so in vulnerable populations, it just becomes even harder getting blood pressure, paying medications, paying for the medications and what have you. So this grant, it's funding from the Patient-Centered Outcomes Research Institute, is meant to look at various ways that we might improve the care of patients with high blood pressure who are part of a vulnerable population.
And for hypertension, I mean, I know there might be a variety of reasons for why, you know, there are certain groups that are more likely to have hypertension, but what goes into that? Is that, you know, food sources? Is that stress levels? What are some of, you know, the possible reasons that they sort of affect this group more than others?
It could be a number of factors. It could be environmental factors. It could be access to healthcare. It could be access to pharmacies. It could be food choices, you know, salt or high-fat diets or processed foods. It could be economic factors related to, you know, accessibility to healthcare and affording copays and medications and what have you. There's increasing attention being paid now to social determinants of health. You know, we know that there are biologic determinants of health, and certainly high blood pressure is a biologic factor, but we know that blood pressure can go up acutely when people are under stress, and so chronic stress may be causing high blood pressure as well. So it's probably many factors that are all, you know, affecting this. The goal of this is to try to address those factors, but also to try to look at innovative ways that we might be able to take better care of patients with high blood pressure.
Absolutely. And for people that go to, you know, say their primary care every year or get labs done every year, this is something that would be, you know, possible to monitor levels, correct? So you're talking about communities that might not have that access or might not be able to go to clinics as regularly, or what are some of the differences there when you say, you know, the access to medical care might not be the same?
Well, patients may not have an identifiable doctor, and patients may not have adequate transportation to get them to that doctor. Patients may not have insurance that helps them get covered to pay for the hospital visit or the doctor's visit or the medications. Patients may be on multiple medications, and so the sum total of expenses for the patient may be excessive. And so you know, there are all kinds of barriers that might be in place that keeps the patient from receiving adequate medical care to treat their blood pressure.
And with this study, it's given to us. It's also in Sentara to this area, but it's also being given to Yale University, Massachusetts General Hospital, and Houston Methodist Hospital. I mean, is there a reason you think for? Is it hospital, or is it also the community itself? Is one of the reasons why Sentara was brought on for this project?
Well, we were brought on, first of all, we've been doing some research with Yale University for some time. And so we had some connections with Yale University, and we were invited by the principal investigators who were at Yale to be part of this consortium of hospitals that are part of this project. But Sentara and our community has unique advantages for this. Sentara has already created an Office of Health Equity and Community Engagement, and Sentara is already trying to connect with communities. And so this project, for this project, we were able to sort of layer a research layer on top of what Sentara is already trying to do, trying to reach out to community-based organizations, develop better relationships with community-based organizations. So that made us sort of an ideal site for this particular project, where the whole point is to try to engage communities and community-based organizations in the project. And so Sentara had already started with that. And I'm going to be working closely with the people that have already done that within our organization, so that we can reach out to those community-based organizations to really have a close relationship with them. African-American churches and food banks and homeless shelters, we have a lot to learn from them on what are the community needs, how can we best approach their community and the people who live in their community. We have as much to learn from them as maybe they have to learn from us about, the actual control of high blood pressure.
And one of the reasons for this study, in terms of the press release and what we've spoken about it, is other methods have not worked, correct, yet, or at least not to the length that you want them to. So this is going to serve as some research to figure out the best way to address hypertension in underserved communities.
That's correct. So we're going to be testing two things. First of all, the first thing we're going to be testing is remote blood pressure monitoring. So we're going to be giving participants a blood pressure cuff that is connected to the internet, which will connect to Sentara. And so we can centrally monitor their blood pressure, but they will be taking their blood pressure at home. And this is something that's really necessary anyhow, to monitor people's blood pressure at home makes sense. What is their blood pressure actually in their home environment for the vast majority of the period of time, rather than when they rush in to see the doctor and it may be artificially elevated or it may not be elevated. But knowing what's happening at home is a very important part of it. So that's the first aspect of it, is remote blood pressure monitoring. And the question is, will remote blood pressure monitoring improve their blood pressure control, as opposed to just the regular way of just monitoring blood pressure by having a patient come in and having it taken in a healthcare setting? So that's the first thing. The second thing that we're going to be testing is whether community health workers, people who are they're better, they're connected with the community, although they're not highly trained medical professionals. They will be coming to the homes of people that are participating in this study. And so will community health workers, through a better outreach and engagement, will they help out in taking care of people's blood pressure? It's possible that, by really engaging patients directly in their homes and where they live and where they work, there may be a level of understanding and engagement that will help patients understand the importance of taking their medications, watching their diet, self-care, that type of thing. There may be an opportunity to improve their blood pressure control through community health workers. So remote blood pressure monitoring and community health workers are the two interventions that we're going to be testing to see if those work. Those are two things that aren't part of routine care currently.
And are these patients that are all on medication for hypertension? Are these patients that some of them are going to be on the healthier end of the spectrum? What are you all really trying to see? Are you trying to see if they do have hypertension that they will stick with their medication and then potentially even lead healthier lives? Or what are some of the things you're hoping for in that demographic?
So we're going to be measuring two things. Number one, we're going to be measuring their blood pressure, okay, and over time. And so what actually gets the blood pressure under control? And so the ability to get someone's blood pressure under control is going to be one outcome. But the other outcome is the sort of the social things, engagement and participation and understanding. So those community health workers are going to be asking patients for a number of patient-reported outcomes. How are they feeling? Are they feeling engaged? Are they feeling like they have a better understanding of their problem and how to take care of their problem? So those are the two outcomes. One is a hard endpoint, their blood pressure. It's a measurable endpoint. And the other is a more softer endpoint of, a patient engagement and patient-reported outcomes.
Right. And then, with this group, what do you all need from the public? You have community organizers or community partners that are going to help, figure out the number of people needed for the study. Are they helping, get people for the study? Do you need community members to volunteer to be a part of this? What do you all need from them?
We're hopeful that we can engage some community-based organizations to be part of this. And the community-based organizations will likely be the site of screening and recruiting patients and participants for the study. But also, we're hoping to create a community advisory board that will help us sort of custom design the study to fit our community so that it makes sense for our community. So having this community advisory board, and we mean that, we want them to advise us on how to do this project. I would not presume to know how to reach out to this community and to know the best way to reach out and engage communities and patients in vulnerable populations in communities. I'm really hoping that I can learn from our community advisory board on the best way to design the study and engage patients and communities so that we can get better control of their blood pressure.
Absolutely. And so, in that way, our study in this area is going to look different than studies that do take place even under the same idea, in Houston or around Yale or in Massachusetts.
Yeah, the way they embark on this study in Houston or Boston or New Haven is going to be slightly different. Now, all of us are going to be operating under a protocol, right? We're going to be operating under sort of a defined protocol because we want to pool the data from all sites and make sense of the data. And so, we can't have, a lot of variation in the way we collect the data. But in terms of, the way we engage patients and communities, it's going to be a little bit different in our community and compared to other communities. In New Haven, I think their focus is going to be on using barbershops and beauty parlors and nail salons and that type of place as a community-based organization. In our community, it's going to be churches, I think, is going to be the primary area. I think that it's probably something that makes better sense for our particular community, in the African American community, particularly in our community. African American churches are going to be a very important part of our approach here. That may be slightly different than what they're thinking about doing in Houston and Boston. So each community is different. And so what fits for our community may be slightly different than the other communities.
Right. And then hopefully that gives you the best research following the 5-year study about this area and how to help, going forward in these communities.
That's right. And actually, there's going to be an opportunity to share among our communities. We may find ways of doing it here in Norfolk and Newport News that we can share with people in New Haven and Boston and Houston, and they may be able to learn from us. we definitely will be able to learn from them as well. And so, sharing best practices on how to reach out and engage communities and people in those communities, I think, is going to be part of this whole project.
And, it's over the next 5 years, but when is it really going to kick off? Are you all trying to, find all the participants in the next upcoming few months here? Or what exactly is the timeline?
So in between now and February of 2024, we're in an organizational period. We're developing we're going to engage our community principal investigators, and for us, it's people that are a part of Sentara's community outreach program, and myself, and we have a community, and we have a project coordinator, Jen May, Cindy Allen, administrator at Sentara, is also very involved in this. So first of all, we're getting ourselves internally organized. Second, we're going to be reaching out to community-based organizations to determine which church and food bank and what have you, who will actually be willing to commit. And so, and we'll develop a contractual relationship with those community-based organizations between Sentara and those organizations. So that's all going to occur in between now and February. And in February, hopefully all of that will be in place so that we can start recruiting participants into the study. We're going to be recruiting participants for over about an 18-month period of time after that. And it's called a stepped wedge approach, where not every community-based organization starts at the same time. It sort of started gradually. There's a sort of a study design reason for that, so that, things that happen in the community or things that happen in the world doesn't happen to everyone. And so those type of trends won't affect this study. And so then we'll be recruiting people over an 18-month period of time through the community-based organizations. Those people, depending upon which community-based organization they're a part of, will be assigned to one of those treatment groups, either the usual care or the remote monitoring, or the remote monitoring plus community-based community health workers. And that will be implemented over a period of time. And then we'll have a follow-up period of time to see how, and to measure the outcomes.
And there's a familiarity with this study, right? That you are going into the community versus, a patient having to go to a hospital or go to an organization to, get tested or any of that. So you all aren't making transportation an issue here. You're not making, maybe appointment times an issue here, correct? Is that what I'm understanding?
Yeah, so for people in the usual care arm of the study, they will be expected to come to doctor's offices the way that things work usually currently, right? But then for the intervention part of it, we're going to be monitoring their blood pressure remotely. And so we'll be able to have a clinical pharmacist that calls them up and at home, or a nurse practitioner that calls them up at home and says, hey, we've noticed that your blood pressure is elevated, what's going on. So there'll be that type of engagement. So it'll be a little bit of a different type of engagement with the patient based on remote blood pressure monitoring. And then with remote blood pressure monitoring, in addition to community health workers, those community health workers will be going, to their home and to the community-based organizations. They'll be meeting patients where they live and where they are. And so that's also quite different than, the standard, care of taking care of patients with high blood pressure currently.
Right. And then a part of the, $3.4 million grant, I mean, patients are not going to have any obstacles in terms of insurance or in terms of payment, to be a part of this study. Are they under that $3.4 million?
The participants get a small stipend for participating. It doesn't take care of their health care, though. The grant is to pay for what we're adding because of the experiment that we're doing. The grant is meant to pay for the research. It's not meant to pay for their care, actually. So, their care is going to have to come, that will be part of what is in place currently. the grant, $3.4 million over 5 years, that sounds like a lot of money, but actually, if that was meant to take care of the health care for our 480 patients, it wouldn't go very far. Now, it's meant to, there's stipends that go to our community-based organizations, and the people who are at those organizations who help us do this work, they're not going to be doing it, for free as volunteers. We plan to engage them and pay them and have a contractual arrangement with them. There will be stipends, a small stipend for participants. We will be paying for the community health workers that go into the communities. We'll be paying for the devices that we use and developing the connections with our electronic health record. We'll be paying for the principal investigators, some salary support for those people, and for study coordinators.
And then one of the last questions I have is, in terms of the study, you are seeing a select group of the population, but what do you hope for the other part? I mean, you've mentioned things like, taking blood pressure regularly, going to visit doctors if you're able. I mean, is there anything that you hope maybe peripherally will happen because people might, be so aware of hypertension? Or is there anything in the community that you, I guess, are hoping for at the end of the 5 years?
Oh, I do hope that we do a better job as a community in taking care of high blood pressure, and hope that because we're involved in this with the community, that we'll create a greater awareness around high blood pressure. I'm hoping that we learn more about our community and better ways that we can engage with our community so that we become more effective. If we're more effective at treating high blood pressure, we would have a substantial impact on care. We would reduce kidney failure and heart failure and strokes and heart attacks and peripheral vascular disease. So many things happen because people have untreated high blood pressure, uncontrolled high blood pressure. Often in African Americans, it's more prevalent, but also it's harder to treat. It's a more difficult problem to treat. And so we may learn ways that we can be more effective at actually controlling that high blood pressure. If you're treating it, but patients can't get access to medications, or if there's some barrier and the treatment isn't working, then that's not good enough. We've got to come up with methods that actually work. And by that, I mean, it actually controls people's blood pressures. That's going to be the important thing. And so I hope at the end of the day, we'll learn better ways that we can do that, but also through better community engagement around high blood pressure, greater awareness, and greater personal engagement on the part of patients and participants in the study, that we'll be able to just do a better job of taking care of people in our community.
Right. So it is trying to, help better outcomes for patients, or, less stress on healthcare, really, if people are not going in for heart attacks or cardiac events or anything like that.
Yeah, the old adage, prevention is an ounce of prevention is worth a pound of cure, right? If we can prevent those health outcomes from occurring, that would be a huge win over the long run. Not only would it spare people of strokes and heart attacks and kidney failure and that type of thing, but there's a huge economic benefit as well. Those taking care of those type of things is very expensive, and so if it makes sense, in many ways, economic, but just caring for people, it makes sense to try to prevent problems through better care of the things that we know are what we call risk factors that increase your risk of developing other problems.
Well, Dr. Brush, thank you so much for joining us. I mean, is there anything else that we did not get to or is really important to highlight, about the study?
I think that I'm really excited about this because it adds a research layer to what Sentara is already doing through their community engagement. Sentara actually does care. They really do care about this and want to engage their community and take better care of people who live in their community. And so by adding this research layer onto it, we'll be able to see actually what does work and what doesn't work. And so at the end of the day, I think we'll be able to do a better job. So I'm very excited about this. And I really appreciate you taking the time to discuss this with me and to help us get the word out about this important project.
Absolutely. Well, good luck with the study. I do hope, it's a successful next few months of planning, and then as well once participants start. And can't wait to see, what the end result is, at the end of this study. And I just want to say, all this reporting too is from Marielena Balouris' report that will be tomorrow night. But hopefully, we're getting the word out here on other platforms as well as on TV tomorrow evening. So thank you, Dr. Brush, so much for joining us today. And thank you all for watching.
Thank you, Sarah.
Thank you.